A 13-year-old boy complains of loss of vision in his left eye. He can't read words over the board, and this condition started since 2 years after blunt trauma to the eye by football, but increased slowly over the past months. He does not wear glasses, and his best corrected vision is 6 over 6 right eye and 6 over 60 over the left eye. His examination is significantly dense lens opacification in his left eye, small corneal opacification in the left eye, as well as bilateral reactive pupil, and everything else is normal. He has a history of strabismus surgery in left eye 9 years ago. Alright, so now let's talk about cataract. This is obviously a case of cataract. The thing is, what might be the cause? Obviously from the cause, you could tell that the cataract is due to trauma from his days in playing football. So the diagnosis here is traumatic cataract. Okay? Now, someone might confuse themselves. Nawaf, what is the difference between opacification of the lens and opacification of the cornea? Do they both mean cataract? No. Cataract means opacification of the lens. If you don't remember the lens is basically this biconvex structure that is found between the vitreous humor as well as between the iris. So you have the cornea, then you have the iris, let's say, and then the iris contains inside the pupil, the hole. Go deep into the pupil, you'll find the lens. The lens, in front of it is the iris, and then in between it is the aqueous humor. Behind the lens is the vitreous humor. And this lens is a biconvex transparent structure, transparent, just like the cornea, and is held together by suspensory ligaments. So I'm a lens with suspensory ligaments, and they're attached to the walls, which we call ciliary body. The purpose of the lens is the same as cornea, in which they help in refraction, transmit the light smoothly, so it contributes to refraction. And the lens is very important in a very, very important reflex that unfortunately we start to lose by the age of 40, which is accommodation reflex. The ability to see closely by the book. Whenever you're reading a book closely to your eyes, your eye will automatically adjust its refractive power to be able to see the text in the book close to you as compared from distant vision. But as we age, we start to lose this accommodation reflex. This is called accommodation. Because the lens starts to lose its elasticity, it becomes more rigid, the suspensory ligaments become more rigid, and we begin with a strong accommodation, very strong accommodation as children, but when we get to the age of 40, 50, and 60, we'll need reading glasses to be able to, ironically, accommodate for our accommodation reflex deteriorating. And if you don't remember the accommodation reflex, it is a natural reflex where you read, whenever you have something, a close object near to you like this, you have a nearby object, your eyes will converge. There will be convergence for your eyes, your pupils, and there will be pupillary constriction, and the power of the lens will increase, meaning through muscle contraction, the lens will get bigger so that more light could get through this object specifically right here. And why am I focusing on the lens? Is because the lens is typically transparent, and if there is opacification in this lens, whether it's due to aging or other causes, that means light will not be able to pass through as smoothly, and you'll have a case of cataract. Patients come to you with leukocoria, whitening of the pupil. And this can come in children, and this can come more commonly in basically very elderly patients, okay? So in this diagnosis for this case, this is a case of traumatic cataract in the left eye. This patient had a trauma to the eye, it led to opacification in his lens, and this leads to development of traumatic cataract. It doesn't develop immediately, even in a case of trauma, it develops progressively. And as it develops progressively with further opacification, you'll start to gradually lose your vision. Your visual acuity will slowly deteriorate, and this will be painlessly. Patient typically will not complain of any pain. The thing is, this is typically the only thing you might see in a patient with cataract. However, if you see a child who is basically blind, he's not able to follow you with his fingers or his mother's object, he has chronic painless visual loss, and he has something known as a squint, where your eyeball, they basically come together and focus on that one direction. So a squint or a strabismus, either this direction or away, cross-eyed. If you see a child that has basically leukocoria, whitening of the pupil, as well as strabismus. In a young child, 5 years old, you have to diagnose this case as soon as possible, because we always assume, even as general practitioners, when I'm going to residency, if I see a child with whitening of the pupil and strabismus, squint, I must assume this is retinoblastoma until otherwise. This is a tumor in the retina with a very bad prognosis if detected early. And these findings that I mentioned before are the classical findings of retinoblastoma, okay? So this is typically important in children. Or in the case of patients, or let's say babies, they are born with cataract, they call it congenital cataract, and they might be born with congenital cataract because the mother had rubella infection. So there was a vertical infection, and then rubella developed a disruption in the baby's development, and this led to congenital cataract from rubella, as well as accompanying symptoms. I mean, not just chronic painless visual loss and cataract, but also congenital glaucoma and microphthalmia, very small eyes or very small eye globular shape. So these are other symptoms you might see accompanied with chronic painless visual loss. But this is, in most cases, especially in acquired cases or in adults, elderly adults, this is typically the only complaint they might have, that their vision slowly deteriorates. So how do I basically investigate cataract? By history and examination, especially examination. I'll do slit lamp examination and I'll observe there is whitening of the pupil. And then I'll do other examination. Like for example, there's a device called direct ophthalmoscope where I examine the fundus of the eye from the inside. I'll also do imaging, especially in a child. Remember retinoblastoma? If I'm suspecting retinoblastoma, I have to do full ophthalmic examination. So I'm checking the eye interiorly from the outside. I'm checking the retina. I'm also checking the pupils as well, ocular motility, everything. And I must include imaging. Imaging such as what? Orbital CT. I'll do a CT scan for the orbit and ocular ultrasound. Like let's say for example, let's say there's a cataract and I'm not able to see the fundus with my direct ophthalmoscope. I must do ocular ultrasound. A type of ultrasound that will allow me to see from the back, from the retina, which I can't see from anteriorly by my direct ophthalmoscope, for example. So I must do ocular ultrasound, orbital CT. This is especially important in case of cataract you'll see in very young children. And then we'll see, okay, this cataract, what might be its possible cause? So this in general for the investigations. Then what about differential diagnosis? This leukocoria, whitening of the pupil, does this mean I have automatic cataract? Maybe, possibly, but before we assume this patient has cataract, we must look at the symptom. So we'll go differential diagnosis based on the patient's symptoms. For example, chronic painless visual loss. Cataract is not the only condition that might cause progressive loss of vision in a painless manner. There are other causes. For example, diabetic retinopathy, a complication in diabetics. For example, people with macular degeneration, another degenerative condition in elderly adults. For example, also patients that might have a case of chronic glaucoma. They might have glaucoma, but they're asymptomatic, and then slowly with the intraocular pressure increasing, it might compress the optic nerve, so their vision slowly deteriorates. There are other causes, and we'll see it maybe in the future videos when we summarize it. But we should think of these as differential diagnosis based on the symptom. If you see a leukocoria, most likely cataract, but we must look at the other symptoms as well. Besides that, before we go to the treatment is surgery, by the way. Always surgery. But before we go to the surgery, let's look at the types of cataract. We divide it into congenital and acquired. We already mentioned about congenital cataract. We consider cataract to be congenital if it's a baby who's born with it. It's a baby who has leukocoria and unfortunately strabismus and other symptoms like a glare. They see abnormal flashes. We'll consider it as congenital cataract. And in this one, whenever we have a congenital cataract, again, we'll assume this cause is associated with retinoblastoma. If it isn't, it might be rubella. It might be other causes, maybe Down syndrome or any other genetic diseases. Regardless, this is congenital cataract. And in congenital cataract, the treatment is surgery immediately. And I'll tell you why, because the complication of cataract is very, very severe and permanent if it develops. This is the first type. The second type is acquired. There is an acquired cause or a possible secondary cause as to why cataract occurred. We already saw one of them, and it was traumatic cataract. When you have trauma to the eye, it might lead to ossification to the lens because the lens is damaged. Besides trauma, there's also complicated cataract. Complicated cataract means if a patient has glaucoma and is untreated for long periods of time, he might develop cataract. All right, so this is an example of complicated cataract. It's called complicated cataract, meaning cataract that's caused as a complication from other eye diseases, glaucoma, uveitis, so forth. Besides complicated cataract, you have metabolic cataract. This is associated with someone who has diabetes for a long period of time. So you might not just have diabetic retinopathy, you might just develop also metabolic cataract, especially associated with diabetes or people with galactosemia. Besides metabolic cataract, you have drug-induced cataract. And there's a very famous drug that might cause cataract if used for a long period of time in high doses, and that is systemic steroids. If a patient uses systemic corticosteroids for long periods of time in high doses, he might develop drug-induced cataracts. And that's with the systemic, and not really with the topical. Topical steroids, they might cause glaucoma as a side effect, most commonly. Besides drug-induced cataract, you also have the most common cause of acquired cataract, especially in the elderly, and that is senile cataract, referring to elderly people. With aging, there might be ossification of the lens, and eventually an elderly patient may develop cataract. And this is most commonly the type of cataract cases you might find in internal medicine, or basically specialties that don't involve children with leukocoria. You might see this in elderly adults. So these are the types to keep in mind. So what about the treatment? And before we go to the treatment, also another cause of acquired cataract, post-surgery. And it's relevant to the surgery as well. We'll talk about it. So let's talk about treatment of cataract. Cataract, is it treated by medication? Of course not. We have to do surgery. And the surgery involves here, there's many types of surgery, but by far the best surgery that will give you the earliest visual rehabilitation is known in America, known as phaco. Phaco is a surgery in which they remove the lens, okay? They go inside, they do a 2mm incision, okay? They do a 2mm incision in the eyeball, and then from there, they will insert an ultrasound probe. That's why they will consider phaco as an endoscopic surgery. So in phaco, they'll insert an ultrasound probe, so this 2mm incision inside the eye, and this ultrasound probe from inside will destroy the lens. Like this, basically. This is the lens and this is the probe, breaking the lens into pieces, okay? And then once we break the lens into pieces, the patient will be considered aphakia. Aphakia meaning patient has no lens. If you hear the term pseudophakia, it means the patient has an artificial lens implanted. If you hear the word phakia, it means the patient has his normal lens in his eye. We're all phakia. But in the case of patients who undergo cataract surgery, they'll be temporarily aphakia. They have no lens. So in the case of phaco, we're going to destroy the lens from the inside, and the patient will be considered aphakia. Does this mean we'll keep the patient living without a lens? No. Once we destroy the lens from within, we will implant an intraocular lens, okay? We'll have an intraocular lens ready, known as a posterior chamber intraocular lens, the best one, and we will basically insert it inside the eye afterwards, and then after surgery, the patient will be very, very happy with his vision returning back gradually and faster compared to other options, compared to other surgical options, okay? So the surgery treatment for cataract, the best is phaco, following with insertion of an intraocular lens. So is this like done immediately? Like do we do the surgery immediately? No, especially in children. Let's say in children we have a cataract that's not associated with retinoblastoma. Let's say rubella. So I'm going to do the surgery, but not immediately, because babies, when they're born, their eye is not fully developed, especially the globe. The globe is slowly maturing in its size. So typically what they do, the ophthalmologist, is that they will remove the lens. They will remove the lens and make this patient aphakia. They do lensectomy or lens aspiration. They remove the lens and keep this baby aphakia for 2 years. Why 2 years? Because after 2 to 3 years, most of the development for the eye growth will be completed. I will not insert a lens while the eye is still developing, okay? So we will remove the lens in these babies, and then once after 18 months or 2 years, this baby's eye will be fully developed, and then we will continue with the surgery. Then we will do the phaco, if we didn't do it already, and we will implant our intraocular lens. Okay, so our intraocular lens will be implanted in this baby after 2 years. We'll do the phaco immediately at birth, but after 2 years, we'll implant the posterior intraocular lens. Okay? So what about in adults? Let's say senile cataract. Do we have to wait? No, we'll do this immediately. Phaco plus posterior intraocular lens implant. Okay? Someone might ask a question. So what about these babies? When we remove the lens through phaco surgery or whatever, let's say not phaco surgery, let's say a case of lensectomy, let's say, so we don't confuse the terms. Phaco is typically we insert the lens, but lensectomy we just remove it. So let's say in the babies, a question. In babies, when we remove the lens, do we just keep them aphakia? Do we just keep them living without a lens? No. During this 2-year period, you will basically give this baby spectacles to treat his aphakia, or basically spectacles special for an aphakia patient. Because here's the thing, when you remove the lens and you leave it untreated like that, baby will not see, but that's not the problem. The baby will not see and he'll develop something known as amblyopia. If you don't know what amblyopia is a condition in which there is deterioration of vision in one eye typically because the brain is neglecting signals that are coming from this affected eye. So if you have one eye with normal vision and one eye was normal vision and one eye was poor vision, the brain will focus on the normal eye and neglect any signals that might come from the affected eye. And if that happens, then there will be a lack of visual stimuli to the eye. The eye will be lazy. That's why it's called amblyopia, lazy eye. So the eye is not going to be working as much, and if that happens, the vision will slowly deteriorate, and this can be irreversible if not treated and detected early. So amblyopia can be permanent. So we will not leave the baby for the next 2 years who has congenital cataract. We will not leave him for the next 2 years without a lens. We will correct this baby who has a refractory error. We will correct the baby and will prevent amblyopia by giving him spectacles. If he has unilateral aphakia, just one lens removed, we'll give him a contact lens. But if he has both lenses removed, bilateral aphakia, we'll give him glasses, very specific glasses, hypermetropial glasses. These are positive sign glasses, okay? Until after 2 years where we will remove his glasses or whatever and we'll complete with the surgery. Phaco plus posterior intraocular lens implant, okay? So that's something to keep in mind as well. Another question, Nawaf, do we just give intraocular lens implant anywhere? Do we just give him any posterior intraocular lens? No. Any intraocular lens implanted to the patient will be according to the patient. So typically these eye doctors, ophthalmologists, they will basically measure the intraocular lens power. They'll measure its power via biometry, some complicated case, and before they implant, they'll do ocular ultrasound to ensure there's no abnormalities in the retina or in the vitreous humor or anywhere in the retina before they implant the lens to prevent complications, because there are many complications that might occur during and after cataract surgery. Okay, so that's something to keep in mind as well. So this is a treatment, surgery. There is a specific type of cataract that might occur, and this is unfortunately the most common complication that might occur after cataract surgery, and that is known as post-surgery cataract or after cataract. This is known as PCO, posterior capsular opacification. You see, typically when we have doctors, when they do this phaco, when they remove the lens, and let's say they don't remove the lens, or let's say in the case of another surgery, they remove the lens except one very specific part of the lens, which is known as the posterior capsule. If you don't remember, the lens has two capsules, an anterior and a posterior capsule. In between is the nucleus and the cortex. So let's say they basically remove everything from the lens except the posterior capsule. They leave it there as a base to implant the intraocular lens. So in the case of PCO, after months or years, not weeks, let's say after years, 2 years after cataract surgery, the patient might come again due to complaints of vision loss. And the reason he has vision loss is because he developed cataract, a different type of cataract, in which these 2 years he basically moved on from cataract surgery. The new intraocular lens that was implanted here, it was causing friction with the remaining part of the original lens. So basically, during surgery, they might keep the posterior capsule of the lens intact, so they can implement the lens implant, the implant of the lens in. But the thing is, after years, there might be friction between the posterior capsule of the original lens with the implant, and this friction might cause ossification for the posterior capsule, and that's why they call this posterior capsule ossification. This is the most common complication that might occur after cataract surgery, and the only treatment for this is a laser treatment. The laser treatment for this is that we will do a laser through this posterior capsule so we can have an opening and we can allow light to pass through the lens completely. The laser treatment is known as YAG laser. This is YAG laser. This is the laser that's used. YAG laser posterior capsulotomy. From the name, we'll have a laser from the YAG, penetrates through this ossified posterior capsule of the original lens to treat after cataract or post-surgery cataract, okay? So that's also something to keep in mind as well. So this is pretty much it for the cataracts, and I hope you enjoy.